This conference will now be recorded.
Now I request our first presenter, Dr. Bushra Nasir.
Assalamu alaikum. My name is Dr. Bushra Nasir. I am PGR Ophthalmology in Shalimar Hospital, and today I am doing a case presentation. A 71 years old male patient was presented to the eye department with the complaint of sudden onset of double vision for the past 1 day. He was in his usual state of health. Then he developed diplopia for near and far, which was sudden in onset, and it was associated with giddiness, and there was a difficulty in walking with no other apparent signs of weakness in the whole body. He was a known case of hypertension for the past 5 years, for which he was taking antihypertensives. He had a history of angina 5 years ago, for which he had to undergo an angioplasty. After 15 days of his angioplasty, he developed Guillain-Barré syndrome, for which he had to undergo 4 to 5 sessions of plasmapheresis 1 day apart. His past ocular history was not significant. His general physical examination showed that he was a normal physique person who was well oriented with time and place. He walked in the clinic and there were no other signs of illness. His blood pressure was 170 by 100, and the neurological examination revealed his muscle strength was 5. All the cranial nerves were intact. I will discuss the third and fourth nerve in the later on slide. His initial ocular examination revealed that his vision in the right eye was 612 partial, which was corrected to 69, and in the left eye it was 66. The intraocular pressures were 14 and 13. We did his Hirschberg test, which was decentralized in the left eye. It showed hypertropia. The right eyelid was ptotic, and it was covering the pupillary border for 2 mm. The MRD was 2 mm in the right eye. His extraocular muscle movements were not smooth, accurate, full, and equal. There was a right eye restricted adduction, and on the left eye there was a abducting nystagmus. The other extraocular movements were normal. This is the video of presentation. At presentation, we can see in this video there is a restriction of right medial practice, and there was a ptosis of the right eyelid. And in abduction of the left eye, it showed nystagmus. The other extraocular movements were normal, and the convergence was normal in this case. We checked the convergence also, but unfortunately that is not recorded in the video. It was intact at the time of presentation. On the basis of his initial examination, the differentials which we narrowed were atypical internuclear ophthalmoplegia, And this is atypical because there was a ptosis also in the right eye. And then we also made a diagnosis of partial third nerve palsy in the right eye because of the medial rectus paresis. And in the left eye, we made a diagnosis of fourth nerve palsy, and the fourth one was myasthenia gravis. To rule out the fourth nerve palsy, we did a Parkes three-step test, which was negative. A Parkes three-step test is done to isolate for the isolated lesion of fourth nerve. In this, it consists of three steps. In first step, we identify the hypertrophic eye in the primary position, and this narrows down the affected muscles to the depressors of hypertrophic eye and one of the elevators of the hypertrophic eye. In step 2, we see that the deviation on which gaze it worsens on the opposite gaze. And in the step 3, we do a head tilt test, which is called Beale-Schwarzschild head tilt test, in which a patient is instructed to fixate on a target at 3 meter and then head is tilted on the either side to assess that on which side the hypertropia gets better. And then we did for myasthenia gravis, we did a Cogan twitch sign, which was negative to rule out myasthenia. So all of these things. Uh, then we did a slit lamp examination in this patient, which showed the adnexas were normal. The eyelid in the right eye, it was mild ptosis, MRD of 2 mm, and in the left eye, it was 4 mm. And the cornea were clear, iris details were visible, pupil were round, regular, reactive, anterior chamber was deep and coiled, the conjunctiva was normal, and the lens showed early lenticular changes, and in the fundus, we saw early macular degeneration that was drusenoid. This is the picture of fundus, a colored photograph in which otherwise it is healthy, but we could see some drusenoid. Uh, then we did a OCT macula for both eye, which showed here drusen can be seen at the junction of the retinal pigment epithelium and Bruch's membrane, and there was a generalized retinal um, sort of disruption of the RPE overall, but more in the parafoveal area, and an epiretinal membrane was also present. We then ordered his baseline investigation, which was complete blood count, lipid profile, and HbA1c, and all of them were normal. And we referred him to a neurologist. The neurologist initially ordered a CT scan brain plane for this patient. And on the CT scan brain, it was a non-conclusive uh, scan, which just revealed that there was a non-specific prominence of and hyperdensity of the vertebral artery and basilar artery. And he labeled him as a case of right-sided stroke, for which he started him with two medicines, paracetam and mecobal. Paracetam is a nootropic drug, which is thought to improve cognitive functions and mental well-being in some patients. But the radiologist who did the CT scan, he advised to further evaluate him with an MRI scan, but his neurologist did not recommend it. With all of these examination and details, we narrowed down our diagnosis to internuclear ophthalmoplegia. And the literature review of internuclear ophthalmoplegia. Basically, internuclear ophthalmoplegia is the lesion in the medial longitudinal fasciculus, and its causes can be any demyelination disorders, stroke, and tumors. There are types of INO. It can be unilateral and bilateral. In unilateral INO, the eyes are straight in the primary position, and there is a defective adduction on the side of the lesion, and there is an abducting nystagmus on the opposite side, and convergence is normal. And in the bilateral INO, there is a limitation of adduction with nystagmus for example, if we are talking about left eye, it is limitation of left adduction, and there is a nystagmus of right eye on right gaze. And same in the left side, if it is a limitation of right adduction and the nystagmus of left eye on left gaze, and convergence is again normal in bilateral eye also. Then there is another type which is called walled eye bilateral internuclear ophthalmoplegia, in which there is a rostral midbrain lesion, which give rise to associated convergence deficiency with bilateral exotropia also and abducting nystagmus. Then we have one more entity which is called 1.5 syndrome, which is a combined lesion of paramedian pontine reticular formation, which is the center for our horizontal gaze palsy, and medial longitudinal fasciculus. The combined lesion on both of them, they on the same side give rise to 1.5 syndrome, in which there is a combination of ipsilateral gaze palsy and INO. The only residual movement left in this is the contralateral abduction, which exhibits abduction nystagmus also. This is an anatomical picture of showing the midbrain and the pons, and here we can see the medial longitudinal fasciculus and the six cranial nerves that are controlling the movements. Basically, in game. Okay. This is the video of the same patient after follow-up, the medicines which the neurologist gave, and in this video we can clearly see there is the dosage was revived, the patient's eyelid was now normal, and there was a mild medial rectus paresis still in the right eye, but the left eye did not show any abduction nystagmus. And in this, the convergence was also intact. And all the other extraocular movements were normal. The take-home message for my case was that a timely referral can be miraculous for the patient, because the brainstem is it is a very important part which consists of many vital centers, and if there is a lesion over there which can be exhibited by any eye finding, so we have to refer him. Early referral can save the patient from valuable suggestion.
So I have two questions. Question number one is, did you check the saccades? And what
Yes.
is the importance of checking saccades in cases of palsies?
Ma'am, basically the saccades are again these are the because the conjugate movements of eye. If we are checking the conjugate movement of eye, so we check saccades and smooth pursuit movement and non-optical reflexes. Ma'am, we checked the saccades and there was a little bit restriction when he was fixating back to the center, but otherwise it was normal.
So with saccades normally, how can you say it was internuclear ophthalmoplegia? Because in cases of internuclear ophthalmoplegia, the horizontal saccades are slowed down, while the vertical saccades they remain intact. My second question is, do you know what is 8.5 syndrome?
Eight and
8.5. 8.5 syndrome is when 1.5 syndrome is combined with facial nerve palsy. We call it 8.5.
Now I request Dr. Labika to present her case.
Assalamualaikum everyone. My name is Dr. Labika Anju. I am a postgraduate trainee at Shalimar Hospital. Today I would like to present a case. So, a 5-year school-going boy resident of Bhagwanpura presented an eye OPD on 12th of September 2023 with the presenting complaint of right eye trauma with the blunt side of the pencil. The history of presenting illness. The patient had the right eye trauma while he was trying to take away the pencil from his class fellows. There was sudden decrease of vision in the right eye, which was associated with moderate pain, watering, photophobia, and redness. His past medical and surgical history was not significant, and his father, according to his family history, his father was Hep C positive. There was no drug history. His past ocular history was not significant, and he belongs to a middle class family. And he achieved his milestones on time, and the vaccination was up to date. On doing general physical examination, the child was well oriented in time, place, and person, and the vitals were within the normal range. After that, we did the visual acuity of the child, and the visual acuity in the right eye was counting finger at the time of presentation, and in the left eye it was 6.6. On doing the pinhole, there was no improvement in the right eye vision. Then we go for the slit lamp examination. On doing the slit lamp examination, we saw that the eyelids were normal in the both eyes, and the conjunctiva in the right eye was chymosed and congested, and there was a perforation in the cornea, and cornea appears to be edematous and hazy. The iris, when we saw the iris, there was prolapse of the iris and incarcerated in the wound, and the pupil seems to be distorted. The anterior chamber was flat in the right eye, and the lens details were not clearly visible, and the left eye was normal. This is the picture at the time of presentation. Basically, the cornea seems edematous and hazy. There was iris incarceration in the wound, and there was an iris tear around 10 o'clock, and the pupil was distorted, and the lens details were not visible, and the anterior chamber was flat. Then we did the anterior segment OCT of this patient, and there was corneal defect, and the iris was incarcerated in the wound. So according to all this initial finding, we have to take an action. So we have two management plan in this particular patient. The first plan that we should go for primary corneal repair with lens aspiration plus minus IOL with anterior vitrectomy, or we should go with the primary corneal repair with assessment of how the eye behaves further. So what we choose and why? First of all, we explain the parents about the guarded prognosis of the patient and did the critical counseling. Then the labs were advised, basic labs were advised, and X-ray orbit was done to see any foreign body. And the procedure we choose in this patient was primary corneal tear repair with anterior chamber formation under general anesthesia. So overall, we gave the 7 interrupted sutures with 10-0 nylon were placed and secured the tear. With iris reposition, an anterior chamber was formed, bandage contact lens was placed. This is the post-op picture of the eye condition on first post-op day. As you can see, there were corneal sutures, and there was still an iris defect at 10 o'clock position. Generally there was a well-formed EC, slightly shallow at 7 or 10 o'clock position, and then distorted pupil, and this patient was kept on further follow-up. Then we did the series of follow-up. On 15th of September, his visual acuity became in the right eye 1/60. The patient said pain settled and the wound secured. There was vitreous prolapse in the anterior chamber at 7 and 10 o'clock position. And there was mild AC reaction and the lens became cataractous. This is the post-op picture. We did then after doing the surgery in September, we did further follow from October to December. Multiple visits were done, and the bandage contact lens removed, and the corneal opacity developed. There was an iris tear at 9 o'clock, and the lens became cataractous, and AC was uneven but quiet. So the medication that were prescribed in this patient was topical NSAIDs in BD, and then we give topical antibiotics along with topical steroids and topical tropicamide. This is the post-op picture of the patient after doing multiple follow-ups. So after doing the first surgery, we go for the second surgery in Jan. The second surgery was lens aspiration with rigid PCIOL and angiovitrectomy. The parents were concerned regarding the poor prognosis. So the post-op condition became satisfactory, and the VN improved and the VN improved to 636 on the third post-op day after IOL implantation. So after about 2 months, the visual acuity in the right eye became 612 with plus 2.5 cell at 25 from the as compared to the presenting condition that was counting figure at the time of presentation. This this is the picture of the patient after doing the IOL implant. There were corneal suture placed at the side of wound. A corneal opacity developed and IOL in place. So literature view, basically the keys to the management. First of all, we should know the cause along with the reconstitution of the globe is required. The causes that can lead to the corneal perforation are many. The mostly important is traumatic. Traumatic can be extrinsic or iatrogenic. The other causes include keratitis, which could be infectious or non-infectious. And degenerative disorder can also lead to corneal perforations, and the strophies of cornea can also lead to corneal perforations. So important is how to manage the perforation. Medically, we can treat the underlying cause, and the other options are to give protease inhibitors like tetracyclines or vitamin C. We can also give antibiotic both topically or systemically, and we can give the steroids. Use very caution in selected cases that have significant inflammation. So the surgical management, if the case is traumatic, it is mostly linear and minimal loss of the tissue, so the primary closure may be helpful. If there are microperforations, they may seal spontaneously or bandage contact lens to tamponade. If the perforation with iris plugging or prolapse from the perforation, then if it is recent, like within 48 hours, we can go for the repositioning of the iris or tamponade perforation with air bubble or glue. If the leakage is old, if the perforation is old and leaking, then glue with the sterile plastic drape circle is used. And if it's not leaking, you see that the fibrin will be overlying and it will heal with adherent iris, or the observation is also another option. Small perforation with a diameter of 2 to 3 millimeter. If the perforation are peripheral, then we have the option of gluing, or we can use the pedicle conjunctival flap. If the perforation is central, we can use the gluing as temporizing measure, and the definitive treatment would be corneal transplant. If the perforations are larger, like more than 2 to 3 millimeter in diameter, then we can go for the corneal transplantation. Then the surgical principle for the management of corneal laceration. Basically, there are suturing principles like which suturing technique or material used in this patient, in any patient, particularly typically monofilament 10-0 nylon suture material on a fine spatula needle is used for corneal suturing. The important factor are in this, first of all, is the depth. Basically, corneal sutures are not usually full thickness, but rather past 80 to 90% of the corneal thickness. The depth less than 80% can cause bone to weigh posteriorly. And the passes. When the suture is passed to the cornea, the needle must be enter perpendicular to the corneal surface, and it should be passed in a single stroke to avoid multiple entries. The needles are used. The bicurve needle with a shorter diameter are used centrally, and for the periphery we can use the larger diameters. It can result in the flattening of the cornea periphery and steepening of the central cornea. So this we can reduce the risk of astigmatism. And then the tightening should be tightened enough to avoid any leaking of the wound. The close examination of the wound integrity with fluorescent can be performed to ensure an adequate watertight seal prior to the completion of any case. So the conclusion is that like corneal tessellation present in different sizes, shapes, and depth. So prompt treatment and management following the established principle can yield the best visual outcome. So the take-home message is although the corneal perforation can be challenging for various surgeons, many treatment options are available, but a personalized approach based on the cause of perforation is the key to successful management. Thank you.
Two questions. Number one. So, okay, to follow up. Did you try to check the status of vitreous and retina?
When there was vitreous prolapse, and we did the basic, we didn't see the retina.
If you can't see the retina, is there any investigation?
Yeah, we scan.
You have done anterior second OCT.
Yes.
You didn't do the scan?
We did the B scan, but I didn't have the document of that, so that's why I didn't
You
mention.
have mentioned.
Yeah, we did the B scan to see the posterior.
Uh, and the next question is, could you please show us the picture of the final ocular status?
Yes. Sorry, मैं करती हूँ.
That is on the right side. Am I right? Is that on the right side?
Yes.
Or both?
Right side के picture.
On the right side. And you tell us that the vision was 6.12.
Yeah, 6.5. Sir, with 2.5.
6.12. With this,
The patient definitely has 612 vision. This is, I think, this is miraculous. Having this much amount of corneal opacity and a torn iris. The- Actually ये हमारी जो पी जी आर है दिस इज लॉस पी जी आर लॉस का मतलब ये है कि ये आजकल हमारे पास नहीं है रोटेशन पे है और इसने जो प्रेजेंटेशन तैयार की हुई थी दैट वाज डिफरेंट और लास्ट टाइम पे हमने इसे कहा कि नहीं वो वाली प्रेजेंटेशन शायद पूरी नहीं है आप ये वाली प्रेजेंट करें और इसमें भी इन्होंने कुछ ऐसी चीज़ें की हैं कि जो हम नेक्स्ट प्रेजेंटेशन में भी आप शायद देखेंगे वो स्पॉन्टेनियस परफोरेशन की हैं तो ये दिस पेशेंट हैड इसमें ना जब विट्रियस वाज पुशिंग बिहाइंड द आइरिस और आइरिस का टीयर था जो एक्चुअल मैसेज जो हम बच्चों को देना चाहते थे वो ये थे कि टू ऑप्शन थी एक तो ये थी कि हम उसी वक्त सारी जो है बड़ी सर्जरी करते और हम उसी वक्त लेंस डालने की कोशिश करते आई यूजुअली गो फॉर कि हम पहले सिर्फ जो है ना लेंस जो रिपेयर करते हैं प्राइमरी कॉर्नियल रिपेयर करते हैं दैट कैन गिव यू ए टाइम अगर उसका रेंट भी है पोस्टीरियर कैप्सूल अगर लेंस का डैमेज भी है तो वहाँ पे एजिस पे जो फाइब्रोसिस हो जाएगी दैट कैन हेल्प यू इन प्लेसिंग द इंट्राओकुलर लेंस एट इट्स प्लेस सर्कस में डाल सकते हैं अदरवाइज आपको फिर और चीज़ें सोचनी पड़ती हैं आइदर इंटीरियर चैम्बर और आपको जो है ना सुपीरियर जो है फिक्सेशन करनी पड़ती है इसमें साइटली डिस्प्लेस लेंस था क्योंकि ऊपर आयरस के साथ एडिमेंट्स बनी हुई थी विट्रियस की तो बट द पेशेंट हैड दिस क्वेश्चन जो हमने आप लोगों से पूछना था आप लोगों से गाइडेंस लेनी थी वो ये थी कि शुड वी थिंक ऑफ समथिंग एल्स प्लस 2.5 के सिलेंडर के साथ दिस पेशेंट इज हैविंग 612 विजन एंड द पेशेंट इज फाइन और इसमें अदर ऑप्शंस हैं कि क्या हमें केराटोप्लास्टी सोचनी है बड़े केराटोप्लास्टी के रोग नहीं आए क्या हमें जो है ना आयरस को सूचर करना चाहिए क्या हमें सेंट्रलाइजेशन ऑफ द आईयूएल की कोशिश करनी चाहिए द पेशेंट इज एक्चुअली हैविंग 612 दैट आई श्योर कुछ नहीं करना चाहिए ठीक है
consensus as well.
जी जी डॉक्टर
So I have a very deep reservation about iris shacking with this haptics of this IUL because it's a hard gel
Rigid.
IUL. So would it have been better that we would have chosen a multi-piece IUL, foldable multi-piece IUL? क्योंकि अगर हमारे पास सर्विस था तो सर्विस की प्लेसमेंट के लिए जो मुझे लगता है कि वन ऑफ द बेस्ट चॉइस एक तो ये ऑब्जर्वेशन मेरे जहन में आ रही थी अगर इफ आई एम रॉन्ग मुझे जरूर आप बताइए
नहीं you are right.
दूसरी चीज ये थी कि पेंसिल ट्रॉमा के बाद एक चीज मेरे जहन में आती है कि because these things they contain some fungus as well तो पोस्ट ऑप मेडिकेशंस के अंदर अगर एक एंटी फंगल की ऐड कर दी जाए
Prophylactic
प्रोफिलैक्टिक यस प्रोफिलैक्टिक करना चाहिए या नहीं
एंटी फंगल के बारे में आपको बताता हूँ कि आई हैव ए वेरी बैड एक्सपीरियंस विद एंटी फंगल्स अभी आप जो नेक्स्ट हम कर रहे हैं हमारी प्रेजेंटेशन है स्पॉन्टेनियस परफोरेशन वाली उसमें एक केस ऐसा है जिसमें एंटी फंगल ऑलरेडी चल रही थी वो कैप्ट ऑन उसमें भी हम बात करेंगे नेक्स्ट में एंटी फंगल के साथ कॉर्निया की जो है ना डेस्टिनेशन ज़्यादा होती है और परफोरेशन अर्ली होती है एंड आई हैव सीन बिकॉज एंटी फंगल जितने भी हैं दे आर ऑल फंगीस्टैटिक या नॉट फंगीसाइडिक। एक एंटी फंगल का कोई ऐसा रोल नहीं है कि हम सिर्फ उसको एज ए प्रोफिलैक्सिस यूज करें। बाकी प्रोफेसर आमिर साहब बैठे। जी सर।
इसको तो नहीं किया हमने आईओपी।
इंट्राऑक्यूलर प्रेशर इज प्रेजेंटली नॉर्मल, वी कैन नॉट टेक इट विद द जो है ना अपने नेशन के साथ, बट द पेशेंट इज कंफर्टेबल। रेटिना जब इसको डायलेट करते हैं तो नजर आता है ठीक है अल्हम्दुलिल्लाह, एंड द पेशेंट इज हैविंग अ वेरी गुड।
जी सर, जो है परकिंस
जी
हमारे
सर
पास
है।
है। जी सर है।
As a principle for PGRs, this is mandatory that any patient who has got trauma, either it is a blunt trauma or it is a perforated injury, he has to be observed for intraocular pressure throughout the life. You cannot leave that patient that you know about he can about कैसे।
थैंक यू सर।
And with this trauma, blunt trauma, you should be educating the patient about the sympathetic ophthalmitis,
Yeah.
which has been reported 2 weeks to 60 days. मतलब 2-3 प्रिकॉशनरी जो है ना, हम अपने जैसे पेशेंट्स को या पीजीआर्स को बताते हैं कि आपने मरीज को बताना है कि ये इसमें तो लकीली वी हैव डेवलप्ड 6-12 विजन, लेकिन पहले वाले के लिए बताना है कि दूसरी आंख जो है दिस इज फॉर द पीजीआर, या फिर दूसरी आंख जो है वो स्लोप हो जाए, ये कमरे की रोशनी जो है अगर ये भी चुभने लगे या नजर कम हो तो फौरन आप डॉक्टर को दिखाएं। ये 3 प्रिकॉशंस आपके पेशेंट को बता देंगे।
थैंक यू।
Now I request our third presenter, uh, Dr. Amna, for his presentation on perforation of the cornea, that is spontaneous perforation.
Assalamualaikum everyone. I'm Dr. Amina Latif, and today I'm going to be discussing series of cases. So starting with case 1, my patient was 41 years old male, presented in OPD with significantly decreased vision and watery eyes for one day. The patient was in his usual state of health when he suddenly developed decreased vision in his right eye and watery eyes. There was no other ocular association. He was a known case of hypertension and was taking medication for that. The past ocular history of the patient revealed that he was a known case of dry eyes with dry mouth and having some previous eye allergies for which he was taking some topical eye drops, including some antibiotics, antihistamines, mild steroids, and artificial tears. He belongs to a middle class family. On journal physical examination, he was a moderately obese patient, well oriented in time, place, and person, walked comfortably in the clinic with no apparent sign of any systemic illness. When we did the ocular examination, the visual acuity at time of presentation in the right eye was hand movement, and in the left eye it was counting finger. There was no improvement with pinhole or best correction in the right eye, but in the left eye it improved till 6 by 18. We couldn't take the IOP of the right eye. However, in the left eye, it was 17 millimeter mercury. On further slit lamp examination, the adnexas of the both eyes were normal. Conjunctiva of the right eye showed mild congestion at the perilumbal area. Cornea of the right eye had a central full thickness perforation measuring 2 millimeter with some superficial vascularization more marked in the right cornea as compared to the left one. The pupillary reaction of the right eye was very sluggish. There was no RAPD, and in the left eye it was round, regular, and reactive. The media of the right eye was hazy, vitreous details were not visible at that time. However, the fundal view of the left eye showed that there was a generalized retinal thinning with peripapillary atrophy, slight disc pallor, and altered macular reflex. Unfortunately, we couldn't retrieve the initial images of the patient at the time of presentation. But this picture of the right eye, which we can see, it was taken on follow-up, in which the eye was quite at that time. Bandage contact lens was placed, and the AC was well formed. There was superficial vascularization encouraging the perforated area. And these are the colored fundus photograph of the right and the left eye, in which we can see that right eye has a bit hazy view, but disc seems to be healthy. In the left eye, there was generalized thinning and with peripapillary atrophy, mild pallor disc, and altered macular reflex. As I told earlier that the patient was having dry eye and dry mouth, so we referred him to the rheumatology department to rule out any autoimmune associated disease. Upon which they advised some baseline investigation in which only the HbA1c became positive. It was 6.2 at that time. They were suspecting Sjogren's, so they advised biopsy of the minor salivary gland, which showed a minimal lymphoid infiltration. So what treatment options we had at the time of presentation? We could have been opt bandage contact lens. We could have been done tassorrhaphy. We could have been used a conjunctival flap slash amniotic membrane graft, or gluing it with fibrin glue or cyanoacrylate. However, as we know that sometimes bandage contact lens doesn't work well in perforations which are of measuring 2 millimeter or more than that. But in our case, initially, as we managed him with bandage contact lens, within 2 hours, the AC started to form, and we basically advised this treatment to the patient and called him for follow-up. Now, moving to the second case. The second case was about a 60 years old male presented with irritation, watering, and redness in his left eye. He was in his usual state of health a year back when he developed irritation, redness, watering, which was sudden in onset, painless, and not associated with any infection, foreign body, or trauma. Unfortunately, this patient also was not enjoying a good vision since his childhood. In his teens, he went through a multiple interventions for his both eyes. The record was not available at the time of presentation. For his right eye, he developed the same condition which he is was having in his left eye. He went through tarsorrhaphy twice, which was failed and successful, and eventually evisceration was done in his right eye. He was taking multiple drugs from different places for his left eye. The record was not available at that time, and he belongs to a lower socioeconomic class. On general physical examination, he was a 60 years old male, normal physique, well oriented in time, place, and person, accompanied by his son in the clinic with no apparent sign of any systemic illness. On ocular examination, the visual acuity of the left eye at the time of presentation was light perception in all four quadrants. The adnexa of the right eye showed the exposed implant, and there was mild anterior blepharitis. In the left eye, it was mild intropion with mebanitis. The conjunctiva of the right eye, the margins of the conjunctiva basically were rolled over the implant. However, the left eye was normal. The cornea of the left eye at the time of presentation, there was a paracentral abscess with impending perforation at 3 o'clock measuring 3 into 4 millimeter, adherent lipoma with superficial vascularization more marked at the paracentral and the temporal area. Iris of the left eye, there was optical iridectomy done from 8 o'clock till 12 o'clock with iridocorneal adhesion. The anterior chamber was shallow more temporally. Cataractous lens was present and the fundus hue was not visible. This is the cross picture of the patient. And as we can see, these are the images of the right eye. Surprisingly, the upper image was at that time when he presented to us.
As we can see, the implant with conjunctiva is rolled over that area. And in the picture below, we can see that the patient actually self-inserted a shell by himself. It was not advised by any ophthalmologist. And we can see that there is mild anterior blepharitis was also present at that time. This is the picture of left eye. When he came on follow-up to us, the abscess was resolved and there was corneal thinning with adherent glaucoma, and optical iridectomy, as we can see, was done from almost 8 o'clock till 12 o'clock. And on eversion of the lid, there was mild mebenitis. What came in our mind, basically the patient was already taking these medications. We could have been opt for culture and sensitivity, but however, the patient was responding well to this treatment. So we just added oral doxycycline and vitamin C. So our diagnosis in the both cases were spontaneous corneal perforation. Now moving to the literature review. How can we diagnose any perforation? It basically has four classical signs. First of all, the perforation along with shalving or flattening of the AC. We can see that there is aqueous leakage at some point, which can be tested with Seidel test. There is also a third telltale sign of the corneal perforation in which brown pigment of the iris can be seen in the wound itself. And if the tissue is infected, sometimes it's a bit challenging because it can obscure the area. This is the cascade or leading to perforation. So basically, sometimes some causes can cause epithelial breakdown, and these includes trauma, dry eyes, foreign bodies, few bacteria, trichiasis, etc. Obviously, these leads to proteases formation, which can do stromal tissue lysis, dysmetocele, and eventually even minor trauma can cause corneal rupture. These are the few causes of corneal perforation, as it also discussed in the previous presentation. However, in these both cases, we managed it medically, and both the patient turned out with very prompt results. So we have, according to American Academy's guidelines, so basically we have to treat the underlying cause, use protease inhibitors, antibiotics, either topical or systemic, and aqueous suppressants. So my take-home message for my presentation today is that if you suspect an impending perforation, right diagnosis and precise management can save the eye. And in these both cases, we tried to manage them medically and added the protease inhibitors, and the results were quite promising. Thank you. Your valuable comments and suggestions are welcome.
I'm very much concerned about the first patient.
Ji ma'am.
The left eye. It was the right eye.
It was the right eye.
I'm very much concerned about the left eye of the patient. Did you do anything for the left eye as the patient has problem? And the same sequence of events could have happened.
Exactly. Exactly, ma'am. Ma'am, the left eye basically at the time of presentation was normal. There was just.
Did you do the Sherman's test?
Uh, Hold on. At that time we didn't. Sorry. But yeah. Sure.
The patient is having dry eyes
Ji.
in both the eyes, and the patient is taking off artificial tear drops. When the patient presented with perforation, then we sent the patient to neurologist to evaluate him, and they evaluated and they started. So now मैंने HCQ
जी
HCQ the patient is definitely have dry eye. And there is a concern of the left eye also. The patient is अच्छा respondent है कि वो आता भी है time भी है but he is comfortable.
Thank you.
Actually, the second occupation is अपने right eye का visual status.
Yes, so basically there was.
इसमें ये तीन सेटेड आई
जी.
होगी आपको इंडियन निकाल के दी क्योंकि वैसे हमारा डिफरेंट आप
जी बिल्कुल
लाइट आ
सर.
रही है नहीं आ रही
जी सर. जी.
ओनली आई
श्योर सर.
The second thing इसमें थी वो ये थी कि the patient came जब हमारे पास अभी वो फॉलो अप के लिए आया तो उसकी दूसरी आंख जो खराब आंख है उससे बहुत खूबसूरत थी. वो बड़ा ब्यूटीफुल शेल उसने बनवा के वहाँ से लगवाया था. इट वाज वेरी सरप्राइजिंग. हमने उनसे पूछा कि यार ये किसने एडवाइस किया. कहते हैं जी डॉक्टर कभी बात कर रहे थे जी इस तरह की आंख लग सकती है और मैंने जाके लगवा लिया. एक्सपोज एक्सप्लांट के ऊपर उसने शेल भी लगा लिया और खुद से लगा दिया. उसके क्या जो है ना फर्दर उसको प्रॉब्लम्स होती हैं, इन्फेक्शन होती है, क्या होता है, यू नेवर नो. अगर आप लोगों को कोई एक्सपीरियंस है इस बारे में तो बता दें. आई हैव टू टेक द फ्यू शेल्स जो एक्सपोज्ड हैं, दे हैव टू टेकन आउट और आप उसको फिर वैसे ही सूचर कर देते हैं. आप अगर वहाँ पे प्लेस नहीं होती सफिशेंट कि आप उसमें शेल डाल सकें. Now I request Dr. Bushra Rahman for her presentation.
Assalamu alaikum everyone. I am Dr. Bushra Rahman. Today I am presenting a case of 40 years old married female who is resident of Bahawal Nagar. She presented in Shalimar Eye OPD on 16 Feb 2024 with the presenting a plane of decrease of vision in her right eye for the last 3 years. On inquiring further, she explained that her decrease of vision in her right eye was gradual in onset, progressive and painless in nature. She had no other associated complaints. She had no history of glasses use, trauma and laser treatment. On digging further, she explained that she underwent multiple treatment for her right eye, but including taking anti-tuberculosis medication, but it didn't improve. She is known case of hypertension for the last 5 years, for which she is taking anti-hypertensive medication. Otherwise, her past surgical history is not significant. Now I am going to explain all the treatment which she undertook for her right eye. For the first time, she presented locally in eye clinic in Bahawal Nagar on 3rd November 2021 with the presenting a plane of decrease of vision in her right eye for the last 3 months. At that time, the doctor did ocular examination. Unfortunately, the findings are not documented. After ocular examination, he advised her B scan and OCT. According to him, he diagnosed her choroidal granuloma. But according to our findings, this B scan shows a lesion arising from the choroid, which has pushed the retina forward. The apex of the lesion is hypercaustic. Behind it, there is acoustic hollowness and orbital shadowing. Her OCT scan shows serous elevation of retina. As the doctor diagnosed her choroidal granuloma, he started her on systemic steroid. But unfortunately, on her subsequent visit after 2 months, her vision was not improved. So he advised her to repeat her OCT scan. This is the image of her left eye, which is normal, and this is the image of her right eye. According to it, the doctor diagnosed her central serous chorioretinopathy. But according to our finding, this image shows a lesion arising from the choroid, which has pushed the retina forward. And there is CS elevation of retina, which is more clearly visible in this image. As the doctor diagnosed her central serous chorioretinopathy, he started her on injection of Avastin in her right eye. She took total 3 injections, one injection each month apart. But unfortunately, her vision didn't improve. So upon her next visit, 6 months after 6 months, he advised her FFA. On the basis of this FFA report, he diagnosed an inflammatory mass in her right eye. But according to our finding, this picture of FFA is taken from the early AV phase, which showed double circulation. As you see,
The retinal vessels are normal, but there are also vessels present behind the retina which are hypofluorescent and crossing all the other vessels. The picture and the other picture shows a well circumscribed hyperfluorescence subretinal lesion which is around 8 disc diameter and it is around the supratemporal arcade. As the doctor diagnosed an inflammatory mass in her right eye, he started her on systemic steroids and antibiotic. She took multiple courses of antibiotic, but her vision did not improve. So, upon her next visit, the doctor thought that this inflammatory mass, as didn't respond to antibiotics, it could be due to TB. So he advised her to TB interferon gamma release assay, which turned out to be positive. So he started her on antituberculous medication. She took antituberculous medication for 10 months, but unfortunately her vision decreased further. So finally, she presented in Shalimar IOPD on 16 Feb 2024. We did her ocular examination. On her ocular examination, it was found out that the visual acuity in her right eye was projection of light in all quadrants. Visual acuity in left eye was normal. Her visual acuity in right eye didn't improve on pinhole and best correction. Her pupil of right eye shows relative afferent pupillary defect, whereas pupil on left side was round, regular, and reactive. Her IOP, extraocular movement, interior chamber, media, and vitreous was normal in both eyes. Upon fundus examination, we found out that on the right side there is neurosentinel retinal elevation with subretinal fluid, and there was large dome-shaped choroid behind the retina projecting into the vitreous. The fundus view on the left side was normal. Unfortunately, we don't have the fundal pictures. On the basis of our ocular examination, our DDs were choroidal melanoma, metastatic choroidal lesion, circumscribed choroidal hemangioma, subretinal hemorrhage. In order to confirm our diagnosis, we advise her B scan. This is her B scan. It shows a bookish picture of choroidal melanoma, which include cholesterol appearance, choroidal excavation, and orbital shadowing. As you see, her lesion is quite large, so we decided to enucleate her eye. So the consultant took advice from another consultant. He also advised the same thing. So her pre-op investigation was done. Her CBC shows that she has low HB. ESR was raised. Rest of the systemic investigation were normal. Her enucleation was done on 20th Feb 2024 and her right eye was sent to the histopathology. Histopathology report confirmed the diagnosis of choroidal melanoma, which was 12 into 11 mm in size. The tumor was limited to the choroid. Opting of dissection margins were free of tumor and there was no lymphovascular invasion noted. After which PET scan was advised to her and it shows that there are no metastases anywhere in the body. Now I am going to present the literature review on the topic of choroidal melanoma. Basically, choroidal melanoma is the malignant tumor which arises from the melanocyte of choroid. It is most prevalent primary intraocular neoplasm. It mainly manifests in the sixth decade of life, is more prevalent in men and in the people of European descent. Basically, choroidal melanoma is a subtype of uveal melanoma. Uveal melanoma has two types, interior uveal melanoma and posterior uveal melanoma. Interior uveal melanoma arises from the iris, whereas posterior melanoma arises either from the ciliary body or from the choroid. So basically, choroid is comes under the category of posterior uveal melanoma. Choroidal melanoma can appear in various forms. Most commonly, it appears as a dome-shaped mass. In rare cases, it can present as diffuse melanoma, in which it shows lateral growth into the choroid with minimal elevation. This type is difficult to diagnose and it is associated with extensive exudative retinal detachment. There are various risk factors associated with choroidal melanoma. The most common is it is most commonly present in the people of European descent and in the people who have light colored irises and history of extensive sunlight exposure. Other risk factors include family history of malignancy and pre-existing melanocytic nevi. It can be easily diagnosed on the basis of A scan, B scan, and FFA. There are various treatment options available for the cure of choroidal melanoma. We can observe if it is smaller in size and we have doubt whether it is melanocytic nevi or melanoma. We can observe it until growth is seen. If the choroidal melanoma is smaller in size, we can opt for plaque brachytherapy. But as you know, in our case, the melanoma was quite large. So enucleation can be done. Other ways treatment options include external beam irradiation, pars plana vitrectomy, endo resection, block excision, laser photocoagulation, and transpupillary thermotherapy. If the tumor has spread to orbit, we can perform orbital exenteration. If there is metastasis, then systemic chemotherapy is the main line of treatment. The prognosis of choroidal melanoma depend upon various features. The number one factor is histological features. In histology, there are three types of cells are seen: spindle type A cell, spindle type B cell, and epithelioid cell. Epithelioid cell is associated with worse prognosis. Other prognostic factors include the size of the tumor, its extension, its location, and the recurrence of the tumor. The conclusion is that as it is malignant tumor and it has the potential to metastasize, so smaller the tumor, greater is the opportunity that spread can be prevented. So, if the tumor can be diagnosed, correctly diagnosed early and treatment can be done, then the life of the patient can be saved. As you know, in our case, the presentation of choroidal melanoma was quite atypical as the patient was female, and you know, choroidal melanoma mostly present in male, and the primary age of presentation is 60 years, but the patient was female and she was 40 years old. So, so our take home message is that we should keep in mind the atypical presentation of the disease. Thank you so much. Now your valuable suggestion and comment are welcome.
Question is that we will go for the systemic investigations
Yes.
before enucleation or after enucleation?
Before,
Did you get the MRI done on that patient?
no. We did the PET scan, it was negative.
PET scan is done for.
To check for metastasis.
What about the extraocular extension?
B scan was done.
The scan orbitally further.
Mm,
Dropping the tires.
it was just IV scan.
Enucleation that is very it is important that we have to rule out extraocular extension. और बाकी रेजिडेंट्स के लिए भी कमेंट्स हैं एक ये कि मोस्ट ऑफ द टाइम व्हेन वी आर ट्रीटिंग अ पेशेंट तो हम एक आई जो है उस पर इतना ज़्यादा कॉन्सेंट्रेट करते हैं वी फॉरगेट अबाउट द अदर आई तो अदर आई जो है समटाइम्स इट बिकम्स मोर इम्पोर्टेंट देन द आई व्हिच इज ऑलरेडी समटाइम्स गॉन और दूसरा पॉइंट जो है वो ये है कि फॉर द प्रोसीजर्स लाइक इनिशिएशन एक्सेंट्रेशन और ई-विजरेशन इन केसेस के लिए इंटरनेशनल गाइडलाइंस ये कहती हैं कि देयर शुड बी टू consultant signatures documentation for e-visitation or acceleration or e-mediation before you go ahead for this destructive procedure. Otherwise, there were beautiful presentations, beautiful ladies. Baki, sir.
थैंक यू वेरी मच डॉक्टर तैयबा। ये बड़ा अच्छा मैसेज है। एक्चुअली जब आप काम कर रहे होते हैं ना, तो यू आर नॉट एक्चुअली डूइंग इट फॉर प्रेजेंटेशंस। बहुत सारी चीज़ें आप मिस हो जाती हैं। जिस इस पेशेंट की हमारे पास कोई एक फंडस की फोटोग्राफ नहीं थी, एक्सेप्ट कि एक जो ओसीटी उसका होगा उसमें आपको रेटना नज़र आ रहा है। आई वॉज आस्किंग द रेजिडेंट्स कि यार रेटना में तो लगता है वाकई हमने, मैं भी देखूंगा तो शायद यही कहूँगा कि कुछ भी नहीं है, ये कुछ थोड़ा सा कोराइडल ग्रैनुलोमा ही पड़ा हुआ है। लेकिन जब इस स्टेज पे वो पहुंचा है, जब इन्यूक्लिएशन उसकी हो गई है, और लकीली, आई विल से लकीली, कि अगर हमने कुछ चीज़ें मिस भी कर दी हैं, तो दी जो पैथोलॉजी की रिपोर्ट उसकी आई है, दैट शोड कि दिस इज मेलानोमा। क्योंकि आई नो ए केस के जिसकी एक बंदे की न्यूक्लिएशन हो चुकी थी। आपने कहा कि दो कंसल्टेंट्स को, लेकिन ये भी है कि दो कंसल्टेंट्स को इंडिपेंडेंटली उसको जो है ना वो असेस करना चाहिए। इट इज़ नॉट कि एक ने कर दिया है तो आप उसके ऊपर साइन कर दें। दोनों कंसल्टेंट्स को अलग-अलग इवेल्युएट करके लिखना चाहिए कि हाँ इसको इस चीज़ की ज़रूरत है। ये जो डिस्ट्रक्टिव किस्म के प्रोसीजर्स हैं हमारे आई के, आई नो ए केस कि जिसको एज मेलानोमा इन्यूक्लिएट कर दिया गया था, और उसके बाद जब उसकी रिपोर्ट आई तो इट वाज ए इन्फ्लेमेटरी मास, इट वाज नॉट मेलानोमा। और वो पेशेंट को 20 साल तक वो उन डॉक्टर साहब के पीछे होता था। वो जहाँ भी कहीं जाते थे वो उनके पीछे पहुंच जाता था। जी मुझे बताएं मेरा क्या कसूर। जी सर, जी सर, जी जी सर, आप बताइए।
Point is very well taken. आपने जो सेकंड किया सो प्रिंसिपल ने जो बात की है, these are the days of social media and patient hyperactivism, or the regulatory bodies are also breathing down your throat. तो इसलिए बहुत जरूरी है कि आप सेफ प्ले करें, अपने आप को जितना बचा कर। तो जो डबल कंसेंट है वो किसी भी कोर्ट ऑफ लॉ में या किसी भी हेल्थ केयर कमीशन की हेयरिंग में आपको प्रोटेक्ट करेगा, जस्ट इन केस, क्योंकि these are the days of evidence based practice. The only thing which protects you is documentation. आपकी अच्छी नीयत जो है, हम सारे अच्छी नीयत से चल रहे होते हैं, but I think it has to be documented to protect you. Or it's for the sake of the residents. I think there is a series on ocular melanoma, which is the best evidence practices. Micrometastasis are documented to be there, happening somewhere. But this patient should have a long-term follow-up with eye index of suspicion that there could be a micrometastasis which can develop.
आपकी बात 100% ठीक है। हम उस मरीज को वहाँ बहावन नगर से यहाँ नहीं ला सके कि वो दोबारा एक दफ़ा हमारे दिखाने के लिए आ जाए। तो उस पेशेंट की फॉलोअप हम कैसे कर सकते हैं? जी सर, thank you very much sir, thank you very much for your comments. Now I request our guest speaker. She is from our rheumatology department. She is associate professor and HOD of rheumatology department, Dr. Sarah Elaine. She is trained in UK, a very good physician. Please come, Dr. Sarah.
Assalamu alaikum. Thank you so much, Dr. Muna, Professor Khalid, and the I department for inviting me for this very important symposium. I also thank my rheumatology department who have also come, because these are diseases that we share in common, and we need to work together for the betterment of the patient. So. I'll start by giving a very brief overview, and then touch upon three diseases that we see commonly in our IOPD. And these are only very brief summary points that I will be mentioning. So basically, a rheumatologist is usually called either to check if there is any systemic manifestation of an underlying eye disease, or when there are other disease treatments that need to be given, like immunosuppressions, which need to be added upon. So keeping this in mind, we are, as human beings, are privileged that systemic complications, autoimmune complications, are very rare in the eye. The reason being that the eye, like the brain, is a very immune privileged site. There are usually no lymphatics except for the ocular surface of the conjunctiva. Uh, cornea is avascular, and there are immunosuppressive factors present in the aqueous humor. Similarly, their tissue express ligands are present which promote apoptosis. Furthermore, it has been seen that if a soluble antigen is entered into the anterior chamber of the eye, the cellular immune response is very much reduced. And this is known as the anterior chamber associated immune deviation. Thanks to all these mechanisms provided by Almighty Allah, eye is not affected that much by immune diseases, but nevertheless, we in our practice see that a lot of systemic diseases affect the eye. These are a list of diseases that include diseases like rheumatoid arthritis, connective tissue diseases, vasculitis, as well as myositis, which have symptoms developing in the eye and causing complications and causing morbidity. So now coming on to the most common finding that we see as rheumatologists that are referred from ophthalmologists is uveitis. So from an epidemiological basis, anterior uveitis is more common than posterior or intermediate uveitis, and it is increased with increasing age of the patients and seen more commonly in women. For my rheumatology team, I am sharing this slide, which is very basic for the eye department. I know anterior uveitis usually involves all the areas in front of the lens and includes iritis and iridocyclitis. Intermediate will include leukocytes in the vitreous humor, and posterior uveitis usually involves choroid and the retina. Panuveitis usually affects all parts of the uveal tract are usually inflamed. So when we talk about acute anterior uveitis, about 50% of the cases are associated with HLA-B27 positivity. So these patients are usually present with a unilateral, acute, and recurrent episodes which are of short duration. They can be associated with raised intraocular pressure and hypopyon formation, and usually recurrent episodes can affect the other eye, but generally speaking, it is a unilateral disease. Of these, 50% of the cases of HLA-B27, about 80% of them have spondyloarthropathies. And just for the ophthalmology department, I would like to explain that spondyloarthritis includes a number of diseases within the same spectrum that share overlapping features. These include not only the axial spondylitis but also reactive arthritis and psoriatic, as well as arthritis associated with inflammatory bowel disease. So the most common type of uveitis that is seen in ankylosing spondylitis and reactive arthritis is the acute anterior uveitis that I just mentioned, and it is similar in both reactive and ankylosing spondylitis. And the lifetime occurrence of this uveitis in our patients is about 33%, which is a lot because we see our population is immense, and there are a lot of patients that come in our tertiary care facility with ankylosing spondylitis, and of these, about 33% will develop uveitis. In case of inflammatory bowel disease, it is less common, 5% and 7% in psoriatic arthritis. The uveitis that we see in these cases is usually more bilateral and chronic. And to compound things further, 50% of these patients also turn out to be HLA-B27 positive. The second most common cause of uveitis in our setup of immune diseases is Behçet's disease. It is also known as the silk root disease because it is more common in those areas, especially in Turkey and those adjoining areas. However, we also see a lot of patients of Behçet's disease, and they usually present with recurrent oral as well as genital ulcers. Uveitis has been seen in these patients in about up to 80% of the cases, and usually 4 years of disease is estimated is present in such patients before uveitis develops, but up to about 20% of the cases will have their first presentation as uveitis. The uveitis in this case is usually acute and recurrent and with recurrent exacerbations, and it is bilateral and non-granulomatous. This is important because this has differentiated from sarcoidosis associated uveitis. Behçet's disease, I would just like to add on, is more of a clinical diagnosis. We do not have any pathognomic test or gold standard test that is present that can identify or diagnose a patient having Behçet's disease. So usually it is the rheumatologist which will be asking the history and looking at the patient and the signs and symptoms to make a diagnosis of Behçet's disease. Now coming on to sarcoidosis. Sarcoidosis is a disease that mimics almost everything. It is something that is not very easy to diagnose, and it can involve the eyes in up to 55% of the cases. And sometimes eye is the only organ system that is involved. In one of the studies that I was reading about, eye involvement is equal to pulmonary involvement. So it can affect any structure of the eye, but most often it affects causes uveitis, but it also can cause retinitis and other problems. When we talk about the uveitis of sarcoidosis, the most common one is the anterior uveitis, and it has very characteristic features of mutton fat keratic precipitates. But this is not pathognomic of sarcoidosis. This can also be seen in other cases as well. Most of the time, the anterior uveitis is chronic, and it is associated with a lot of complications like anterior and posterior synecdoche formation and raised intraocular pressure. Of all the cases of intermediate uveitis, about 18% can be caused by sarcoidosis, and it can give the typical appearance of strings of pearl. Posterior uveitis is also seen in about 28% of the cases and is an important cause of loss of vision in these patients as well. In tertiary care setups, and I'm sure that would be the case in Shalimar, the percentage of pan-uveitis may be reported far more than in the primary care settings. Because in the studies done abroad, they showed that about 37% of the cases were having pan-uveitis. So how do we diagnose sarcoidosis? As I said, we need a tissue biopsy. It's the gold standard. We cannot get a tissue biopsy from the eye. It is in most of the cases not possible and causes a lot of complications. So in the presence of compatible uveitic picture, which of course is what information we rely on the ophthalmology department to give us, and we look for either tissue biopsy if it's of a systemic present in other systems, so that we can confirm the diagnosis of sarcoidosis, or request just CT to look for bilateral hilar lymphadenopathy. ACE levels do not confirm the diagnosis of sarcoidosis. It is the tissue biopsy or bilateral hilar lymphadenopathy that can show the presence of sarcoidosis. It is very important in these patients to exclude syphilis and tuberculosis, as it is very common in our setup. Uveitis unfortunately affects the children. In 3/4 of the cases of uveitis affecting children, the cause is JIA, which is juvenile idiopathic arthritis. The typical patient is a female child who is less than 8 years of age and has had disease for about less than 4 years. The joint diseases usually are polyarticular, that means it involves less than 4 joints, and they have a positive ANA antibodies and are usually asymptomatic. Eye disease can be bilateral, persistent, and may be associated with a lot of complications. Um, this is not visualized very well over here, but briefly, this is an algorithm which is easily available on the net, which shows that a patient with JIA who is positive for ANA is of a female child less than 7 years of age should be monitored in the eye department every 3 months. For patients who are polyarticular, ANA negative, have a disease duration more than 4 years, more or more than 8 years of age, usually we recommend that monitoring for uveitis should be 6 to 12 monthly. Similarly, if a patient, a known patient of uveitis is, we are considering tapering treatment for such patients, then we suggest that when we are tapering topical corticosteroids, a monthly examination should be carried out by a ophthalmologist, whereas a 2 monthly evaluation if we are tapering the systemic treatment. For a patient of uveitis, according to our guidelines, if they are not taking topical steroids, the first line of therapy usually is topical corticosteroids. However, if a patient is taking topical corticosteroids for a long time, almost 3 months, then and is not on any systemic therapy should be added by the rheumatologist. If they are already on a systemic therapy and they're developing uveitis that is not responding to topical therapy, then there need to be a escalation of the systemic therapy, and a review of such patients should be carried out by a rheumatologist. In cases where the chronic arterial uveitis is well controlled, usually we recommend that topical therapy should be discontinued first and tapered first before considering tapering down systemic therapy. And usually treatment is given for about 2 years before we can consider tapering of systemic therapy. The next common referral to us is because of dry eye disease. Dry eye disease is the most common type of a disorder that is seen in elderly postmenopausal women. Basically, it is multifactorial disease caused by irregularities in the osmolarity of the tear film, and it can be multifactorial, causing instability and hyperosmolarity of the tear film, as well as causing inflammation and therefore damage and neurosensory abnormalities. These are the common symptoms that we all experience, and these can really cause a lot severe distress for the patient. For my rheumatology fellows, I've highlighted the tear film because it will show where exactly in the systemic diseases Sjogren's affects the tear film. Basically, the tear film consists of 3 layers. The first layer is a mucin layer, which is produced by lacrimal glands and acinar cells. The aqueous layer, which is produced mainly by the accessory lacrimal glands, and the lipid layer, which is produced by the meibomian glands present in the eye. The dry eye disease is very multifactorial. As rheumatologists, we deal with this portion of the dry eyes, which is caused by deficiency of the aqueous fluid that is produced by the lacrimal glands. So when we're talking about evaluating a patient with dry eyes who has underlying Sjogren's syndrome, a study was conducted which showed about 227 patients who had dry eyes. Of this, half of them had underlying rheumatic disease. And about a quarter of that rheumatic disease was due to rheumatoid arthritis, and another quarter due to primary Sjogren's syndrome. In cases of rheumatoid arthritis, the diagnosis was present with the dry eye disease. That it was a patient who was having long-standing rheumatoid arthritis in which the disease was seen. However, in case of primary Sjogren's syndrome, the disease may have been present for this may be the first presentation of the disease, and it was only a diagnosis that was made by rheumatologists prior to that in only 33% of the cases. Furthermore, I would like to highlight that the lab test that we carry out for the diagnosis of Sjogren's syndrome, in 66% it may have the tested patients who had anti-Rho and anti-LAVA antibodies positive. In 30% only ANA was positive. That means that the rest of these antibodies were not present. And in 16% of cases, none of these were present, and it all was dependent on the biopsy that was carried out. So a patient can have primary Sjogren's disease in the absence of anti-Rho and anti-La antibodies. So Sjogren's disease is basically a chronic autoimmune disease that affects the lacrimal and salivary glands, and it leads to dry eyes as well as dry mouth. And the patient are usually diagnosed. There's a diagnostic delay of about 10 years before Sjogren's disease is detected. And this is a very important because during this time period, a lot of ocular manifestations can develop. And if it is detected early, some ocular complications like corneal melting that we were just seeing in the previous cases can be prevented, as some systemic manifestations which can be life-threatening. There is a few, 5 simple questions, if even an ophthalmologist can remember them, that you can ask a patient, and these have high sensitivity and specificity for showing that there is a Zika symptoms that are present, and maybe divert you towards sending the patient to the rheumatology department. And these include simple questions like, can you eat your roti or your tikka without having any glass of water with you? Or can you, how is your dental hygiene? Are you losing a lot of teeth lately? Or have you experienced tearing in the last week, or are you able to cry? And smoking, the absence of smoking is important because that itself can trigger a lot of dry eyes and dry mouth. So these are just simple questions that can be asked within a minute. So there's an exhaustive list of antibodies and tests which can be carried out once you refer the patient to us, and after checking the patient for the symptoms and the clinical assessments, we will be carrying these out in our department. From the ophthalmology department, we do expect that actually this is not being shown here properly. Simple tests like Sherman's test or tear film breakup time or osmolarity can be done to aid us in diagnosing our case, because as I said, the patient may just have dry eyes and dry mouth, and we need to have evidence that there is that this is positive by the eye department. Simple ways to treat it, which we are all familiar with, but we normally do overlook, do make a lot of difference, which includes keeping yourself hydrated, having a humid room available, avoiding irritants and drugs that can cause dry eyes, and even wearing glasses. A lot of drugs are not available in Pakistan. The only ones that we know about are the topical cyclosporins that are given by ophthalmologists. And none of the autologous serum, as far as I know, is available. I'm sure you can correct me on this, but if this was available, it could prevent a lot of morbidity in the patients. Now my final presentation is about scleritis and episcleritis, which is seen in our patients. Again, for my rheumatology department, the sclera is the white portion of the eye that we so commonly see, and episclera is the layer above it. The topmost layer is the conjunctival layer, and below that is the Tenon's capsule and episclera. Between them are blood vessels that can be affected by vasculitis. Sclera is actually very similar to tendons in a lot of respect, in the sense that it also has collagen fibers, and if their cells are grown in a culture, they can also give rise to the collagen type 2 that is seen in our patients for of rheumatoid arthritis. And similar to our tendons, it has a very less vascularity and no lymphatic vessels, and that is maybe the reason why they share a lot of diseases with rheumatoid arthritis. So this is just a recap on my fellows. Episcleritis can be diffuse or nodal, and scleritis can be diffuse, nodular, necrotizing without inflammation and with inflammation, and posterior scleritis. So posterior scleritis is usually seen with systemic inflammatory conditions in about 40% of the cases, and it's usually a recurrent disorder that is commonly seen. So, and the nodular posterior scleritis usually can present as a mass lesion, and this can be mistaken for a malignancy and having devastating effects for the patient. The most common one, scleritis, is seen in about 30% of patients with systemic inflammatory disease, which are usually women, and it is bilateral, and there are much older than patients with episcleritis. Episcleritis is usually a benign condition, and it is does not normally require a lot of systemic immune therapy, and it resolves spontaneously in most of the cases. So both cause redness, but in posterior scleritis, redness cannot be, of course, appreciated. Both cause severe pain, visual activity is preserved in anterior scleritis, whereas that may not be the case in posterior scleritis. And it can cause a lot of complications, especially scleritis can cause uveitis, decreased vision, peripheral ulcerative keratitis, and raised intraocular pressure. Episcleritis, on the other hand, is a milder form of a disease. So, for rheumatology perspective, when we are thinking of treating scleritis and episcleritis, for episcleritis, we usually recommend topical therapy. In most of the cases, the patients recover. In case of nodular scleritis, we recommend a 6 weeks trial of NSAIDs with topical steroids. If there is no response, then we can escalate to corticosteroids and immunosuppression. And for severe diffuse or nodular scleritis, we usually recommend corticosteroids and conventional DMARDs from the beginning, going on to anti-TNF if the patient is not responding, and eventually to rituximab if needed. I would like to add that now tofacitinib is also available, which is a oral therapy twice a day that can be given to a patient, giving good response to patients with scleritis and for managing our systemic diseases. Cyclophosphamide can also be given. This is basically for those patients who are non-responders, have rapid remission is required, and usually it is combined with agrimethylprednisolone therapy. So usually necrotizing scleritis takes a longer time to achieve full remission, especially in bilateral cases and those associated with systemic inflammatory diseases. I would like to add the most common causes of scleritis from a rheumatology perspective is caused by rheumatoid arthritis and granulomatous with polyangiitis. With rheumatoid arthritis, the diagnosis is usually present, and it is apparent. It is a patient who has long-standing rheumatoid arthritis that has been present for about 10 years or so, and has other complications of RA as well. Such patients are always prone to having vasculitis in other areas of the body as well, whereas GPA can present as scleritis. So GPA is one thing that we need to detect early in our patients to prevent life-threatening complications from developing. So I would like to stop now and thank you and ask any questions if needed. Sure.
Assalamualaikum, Dr. Saira. It's a very engaging discussion today. I think it's really important for our junior residents to realize the importance of being in a tertiary care hospital where we have access to colleagues such as those in our rheumatology department, urology department, and others, where we need to collaborate and communicate to improve patient care. A patient such as the ones we presented earlier, who presented with dry mouth, dry eyes, it's really important to do a systemic evaluation and then refer the patients appropriately. We can manage them on the ophthalmology side, but we do need our colleagues to weigh in to see if these patients would benefit from the systemic management of their underlying diseases. And so thank you so much. It was a lovely overview of a lot of autoimmune diseases that affect the eye. And I'd like to pass this on to anyone else who has questions.
Thank you so much. Thank you.
Thank you very much, Dr. Saira. Now I hand over the stage to Professor Dr. Nasir Chaudhary for presentations.
Thank you very much, sir. First of all, I would like to extend my gratitude to Dr. Saira Alien for such an illuminating and insightful talk. Uh, we, as an ophthalmology society of Pakistan, like other professional societies, they tend to incorporate interprofessional communication and promote these interdisciplinary linkages. Because these interdisciplinary linkages and professional communication certainly promotes better patient care. And then I think we need to give big round of applause to Dr. Saiba. She is the head of department, Dr. Muna, Professor Dr. Khalid Najmi, and team Brigadier Imran Basit Saab for excellent presentations by their residents. इसमें मेरा ख्याल है कि जो पूरी रिमेन इंटरेक्टिव जो दो क्वेश्चंस आते थे हर केस पे प्रोफेसर तैयबा के उन्होंने चार चांद लगा दिए फिर देन अनदर एक्सीलेंट मैसेज फ्रॉम प्रोफेसर हमारा इनको बड़ा जबरदस्त क्योंकि सिंपैथेटिक ऑप्थेल्माइटिस में मुझे याद है कि इट वाज अराउंड 2012-13 की बात है हाफसाबाद का एक बच्चा था उसकी तकरीबन 8 से 10 साल उम्र थी और he ended up with the sympathetic ophthalmitis और वो तकरीबन मेरे ख्याल है कि उसको राइट आई में कार्नियल टीयर था लिम्बस टू लिम्बस विद आइरिस प्रोलैप्स और वो हमारे पास प्रेजेंट किया विद इन 3 months और उसको प्रेजेंटेशन पे मटन फैट केपी से और डेलन फुक्स रिड्यूस भी थे और उसको हर हमने थोड़ा सा कंजर्वेटिव रह के हमने उसको ओरल स्टीरॉइड इम्यूनोसप्रेसेंट्स पे ट्रीट किया और फॉर्चुनेटली वो रिकवर कर गया लेकिन एग्जैक्टली 8 से 10 महीने के बाद दोबारा रिकरेंस पे आया और फिर जाहिर है कि ओनली आई थी और फर्स्ट टाइम मेरे ख्याल उसकी विजन अराउंड थी 612 के आसपास थी वो ज्यादा डिटोरिएटेड थी अराउंड और उसी जो प्रेजेंटेशंस के साथ तो वी हैड टू इन्यूक्लिएट द एक्साइटिंग आई वो क्योंकि ओनली आई थी तो उस वजह से रिकरेंस आ गई थी तो सो आपका मैसेज दैट वाज वेरी सॉर्ट ऑफ वी शुड रिमेन केयरफुल इन केस ऑफ दिस ट्रॉमेटिक केसेस कि उनको जो मैडम ने जो एक जो बेसिक सिम्टम्स आपको बता दिए कि एटलीस्ट उसके साथ पेशेंट को जरूर गेज रखें बाकी वो राशिद का क्वेश्चन बड़ा वैल्यूएबल था वो निकल गए अभी तो अब मैं रिक्वेस्ट करूंगा हमारे जॉइंट सेक्रेटरी अमी अरशद साहब कि वो इस केस प्रेजेंटेशंस को जो इनकी पोजीशन है वो अनाउंस कर दें And meanwhile, we warmly welcome and congratulate Professor Dr. Huma Kiani
She has recently assumed the charge of principal Haja Safdar Medical College, Sialkot. अच्छा हाँ ऐसे नहीं एक मिनट
It's a pleasure for me to announce the results. All the presentations were जिसको कहते हैं ना ज़बरदस्त, बहुत अच्छा केस बच्चों ने तैयार किया हुआ था और बड़ा हमने इसको एंजॉय किया और पीछे रेजिडेंट बच्चे हैं, उनके लिए भी एक लेसन है कि पढ़ के भी आया करें, केसेस ऑलरेडी नोन होते हैं तो क्वेश्चन वो किया करें रादर देन कि फैकल्टी जो है इनको इंगेज करें ताकि आप लोग अपने नॉलेज को अपडेट करें। तो थर्ड पोजीशन के लिए जजेस ने बहुत कोशिश की इसको प्रॉपर हम एवेल्युएट करें, तो थर्ड पोजीशन है बुशरा नासिर। और सेकंड पोजीशन गोज टू डॉक्टर आमना लतीफ। फर्स्ट पोजीशन के लिए जो सिलेक्शन हुई है वो है अगेन बुशरा है लेकिन रहमान वाली बुशरा। कंग्रेचुलेशन टू ऑल द रेजिडेंट्स, प्लीज कम एंड
चलिए थैंक यू। अब मैं रिक्वेस्ट करूंगा प्रोफेसर हारून साहब हमेशा हमें पैटर्नाइज करते हैं एज रिगार्ड्स ऑफ टीचिंग एंड ट्रेनिंग, और अभी एक बड़ा ज़बरदस्त किस्म के सीरीज ओएसपी के प्लेटफॉर्म से शुरू करने लगे हैं जो वर्क प्लेस बेस्ड असेसमेंट है। तो उसमें एक तो है थोड़ा सा हमारा जो एल्कोन के साथ हमने प्लान किया हुआ था, वो फॉरेन स्पीकर एक लेके आ रहे थे और वो ऑल अक्रॉस द कंट्री डिफरेंट जगहों पे प्रेजेंटेशन सेशंस करने थे, तो हमारा भी उनके साथ प्लान था और उसी में हमने वर्क प्लेस बेस्ड असेसमेंट प्लान की थी, लेकिन अनफॉर्चुनेटली थोड़ा सा वो प्लान का वो चेंज हो गया, तो फिर इंशाल्लाह वी विल बी होपिंग सून उसको भी हम करेंगे और इंशाल्लाह हमारी जो क्लिनिकल मीटिंग्स हैं उसमें भी इंशाल्लाह उनको कमिंग जिसमें हम ज़्यादा ऑडियंस एक्सपेक्ट करेंगे तो उसमें हम शुरू करेंगे। तो मैं प्रोफेसर अहमद भट्ट साहब से रिक्वेस्ट करूंगा आए और पोजीशंस के लिए, और प्रोफेसर हुमा कियानी और प्रोफेसर खालिद नजमी और डॉक्टर मोहन्ना आप आए। और जो थर्ड पोजीशन के लिए पहले मैं बुलाऊंगा बुशरा नासर। बुशरा नासर जो थर्ड पोजीशन के लिए, हम इनको सर्टिफिकेट, शील्ड और कैश प्राइज भी देते हैं उसकी तरफ से। और ब्रिगेडियर इमरान वासिफ साहब आप भी आगे से। कैश फंड बच्चे उधर देखें। अच्छा सेकंड प्राइज है आमना लतीफ। इमरान साहब आ रहे हैं आप? इधर इधर मेरे साथ जो फर्स्ट पोजीशन के लिए बुशरा रहमान, बुशरा उनके लिए उनको बुला रहे हैं। आ जाए डॉक्टर सायरा आप भी आ जाए। मैडम आप लोग भी आ जाए, प्रोफेसर तैयबा और मैडम। डॉक्टर सायरा डॉक्टर साहिबा सायरा हमारी चीफ प्रेजेंटर थी, तो इनके लिए एक बोके भी है और शील्ड्स भी।
I would like to call my team, Dr. Shabnam and Dr. Faiza.
चल आ जाइए आप भी। ये सर आप
My team के बगैर Dr. Shabnam और Dr. Faiza basically manage all the patients.
ये बोके भी अब मैं प्रोफेसर हामिद भट्ट साहब, प्रोफेसर हुमा, इनसे रिक्वेस्ट करूंगा कि आपने चेयरपर्सन डिपार्टमेंट और प्रोफेसर खालिद रफी साहब को बुके पेश करने हैं फॉर एन एक्सीलेंट अरेंजमेंट ऑफ क्लिनिकल मीटिंग। नहीं, वो भी करवा देंगे, वो करवा देंगे। मैडम आप उस साइड पे, मैडम भी साथ
दोनों साथ एक ही बुक है, दोनों
जी जी, एक ये एक फाइल चाहिए, फाइल चाहिए। मैडम आप लोग आ जाइए, आप लोग आप आ जाइए। अच्छा, अब मैं रिक्वेस्ट करूंगा प्रोफेसर हामिद भट्ट साहब से कि मैडम ने रिसेंटली चार्ज एज्यूम किया एज ए प्रिंसिपल, तो उनको एक बुके पेश कर दी है।
अच्छा, इससे बच गया है।
नहीं, बच नहीं गया।
एक प्रिंसिपल से दूसरे प्रिंसिपल मैं कुछ कहना चाहूंगी।
जी जी जी, एक बुक है। अब मैं, क्योंकि खालिदा नजमी साहब और मैडम मोना की पुरजोर फरमाइश पे आपने एक बुक प्रेजेंट करना है प्रोफेसर हामिद भट्ट साहब को, ठीक है? ताहिर साहब आप भी आ जाए, डॉक्टर ताहिर साहब, ताहिर साहब। हो गया? वो दे दीजिए। उसके बेटे है ना, हैं? अच्छा, अब मैडम ने, चलिए सर, थैंक यू। मैडम ने बात करनी है, इसके बाद कंपनी का शुक्रिया मैंने बाद में करना है खाने के लिए।
Assalamu alaikum. मेरा नाम प्रोफेसर डॉक्टर हुमायूं सहगल है and I've spent 31 years in Fatma Jana Medical University as a student and then सारी की सारी training. So मैं सिर्फ एक रवायत बताने लगी एक्चुअली जो मैंने नोटिस की थी हामिद साहब ये आपकी है. Sir Hamid walked in 2002 December. याद है मुझे. And Sir left in 2013. It was sudden entry, sudden exit. I was there then and I was there the day he left. I was in theatre and I realized that I was told that the Sir has joined Sims as the principal. And उस दिन मैंने मजाक में सोचा था कि अच्छा, so all these people are mine now. So I did exactly the same. It was a sudden exit from Fatma Jina. So, but I made sure कि सारे के सारे all the beaches are taken care of. रवायत में क्या बताने लगी हूँ? Sir Hamid, Principal Sims. Nadeem Bhatt, Principal AIMC. मियां शफीक, प्रिंसिपल LMTC. उसके बाद जाहिद कमाल साहब, प्रिंसिपल साहिवाल एंड प्रिंसिपल लेवल. नहीं, I'm talking about Sir Fatma Jana. फातिमा जना and then it's me. So अगर आप लोगों ने प्रिंसिपल बनना है तो फातिमा जना का रोल करना पड़ेगा.
अब सिर्फ मैं हामिद भट्ट साहब से रिक्वेस्ट करता हूँ कि कंपनी का मैं शुक्रिया अदा करने सर्टिफिकेट सर आप आ जाए मेरा। कैसर फ्रॉम लतीफ ब्रदर्स, जो लतीफ ब्रदर्स हैं उन्होंने इस सारी जो साइंटिफिक सेक्शन है उसको स्पॉन्सर किया सर। नाम क्या उसका? जो हमारी 4th पोजीशन थी लबैका, इनकी सर्टिफिकेट रह गया था। इसी के साथ सबका बहुत शुक्रिया, स्पेशली हमारे जो चेयरपर्सन मैडम मोना और प्रोफेसर खालिद नकवी और पूरी टीम का फॉर एन एक्सीलेंट अरेंजमेंट और होस्टिंग के लिए। और हमारी जो अगली क्लिनिकल मीटिंग होगी वो होगी LRBT में 8 जून को, और बाकी खाना तैयार है तो सारे लोग सीख लें। अच्छा, एक बल्कि हमने उनको आज सर आप आज प्रोफेसर साहब
डॉक्टर अजहर भट्ट के लिए जो है ना फातिहा आप प्लीज कीजिएगा। उनकी अभी रिसेंटली डेथ हुई है, बड़े अच्छे दोस्त थे, वॉज वेरी नाइस मैन, और बहुत हम्बल, बहुत अच्छे, ऑलवेज लविंग, और हमेशा वो पुअर पेशेंट्स के लिए, हॉस्पिटल्स के लिए, ह्यूमैनिटी के लिए काम करते हैं। प्लीज। लंच इज रेडी, प्लीज आ जाइए।
सर इधर 2 मिनट आ जाए, वो मैडम ने ना तस्वीर बनवानी है, तो मैडम को कह दिया, हेड ऑफ डिपार्टमेंट।